All right. Hello, everybody. My name is Matt Rettig. I'm a medical oncologist at the VA in Greater Los Angeles. I'm a professor of medicine urology at our affiliated academic institution, UCLA. This afternoon, we're going to be talking about advancing care for veterans no longer settling for enough, enhancing treatment of hormone-sensitive prostate cancer. And here are my disclosures. And this activity is supported by an educational grant from Bayer Healthcare Pharmaceuticals. And here's the accreditation information. I won't go into this in too much detail. And here's how to receive the credit. Of course, you have to watch the webinar, complete the online evaluation, and you'll be able to print your certificate. If you have any problems, you can email plexuscom.com. Okay, so here are the learning objectives. Analyze the most recent safety and efficacy data regarding the treatment intensification strategies for castration-sensitive prostate cancer, CSPC, including the addition of docetaxel and/or novel hormone therapies to ADT. 2, to develop intensified treatment plans for patients with CSPC based on patient-specific factors, latest best practice treatment strategies, recent clinical trial data, and expert recommendations. And finally, formulate appropriate strategies to identify and manage AEs associated with intensified treatment approaches for CSPC by utilizing effective and coordinated multidisciplinary care teams. Okay, so this is the outline. We'll start off with emerging treatment considerations for MCSPC. We'll go over sequencing and combinations and develop paradigms in advanced prostate cancer. So we're going to start here at metastatic castration-sensitive prostate cancer. Now, historically, most of the drugs that have been initially developed in prostate cancer have been developed in the metastatic castration-resistant space. And over the last about 6-7 years, what we've seen is that many of the drugs that have modest activity in metastatic castration-resistant prostate cancer have much greater activity, have much greater benefit on median overall survival when they're brought earlier in the disease, especially in the metastatic castration-sensitive space. And that's a general paradigm of oncology, that bringing drugs earlier in the disease, especially if they have some activity later on in a particular disease state, results in a greater impact on outcomes. After we talk about metastatic CSPC, we'll talk about non-metastatic CSPC or PSA or biochemical recurrence. So these are the clinical trials that have been performed in MCSPC. Of course, in 1941, we had androgen deprivation therapy. Huggins and Hodges published their seminal papers demonstrating the impact of medical and surgical castration on metastatic prostate cancer in dogs and men. And Charles Huggins went on to win the Nobel Prize in 1966. It was then in 2013, 14, 15 that we demonstrated that adding docetaxel chemotherapy for 6 cycles improves overall survival. And then there was a series of studies that demonstrated that adding a second novel hormonal signaling inhibitor, be it an androgen receptor antagonist or CYP17 inhibitor, also improves overall survival compared to ADT alone. And then most recently, over the last couple of years, we have 2 studies that demonstrated a triple drug regimen is better than a 2-drug regimen, at least when that 2-drug regimen contains chemotherapy. Okay, so I think this is an important table that it's actually useful for me when discussing prognosis with patients with MCSPC. Now, the numbers here are median overall survival with ADT only, so just ADT. And the 2 factors that are considered here are the volume of disease and whether the patient is presenting de novo with metastatic disease or metastatic disease develops in recurrent fashion after, say, definitive surgery or radiation. And if there are two adverse factors, that is high volume and de novo, the median overall survival is 3 years. If either one of the factors is adverse, then the median overall survival is about 5.5 years. And if they're both favorable, the median overall survival is greater than 8 years. So I have a lot of patients that I see with recurrent low volume, and when you tell them that their median overall survival now is approaching a decade or more, it can be very anxiety reducing for these patients. So it's important to keep these numbers in mind. Okay, so let's go over the data with ADT plus a second agent. There were 4 different drugs that were tested: docetaxel chemotherapy, abiraterone with prednisone, abiraterone being a CYP17 inhibitor and inhibits androgen production. And then we have the lutamides, which are androgen receptor competitive antagonists, where there's a linear relationship between their concentration and their inhibitory effect on the androgen receptor. And those are apalutamide and enzalutamide. And on the right, you can see that the benefits are seen for all patients with the lutamides, enzalutamide, apalutamide. With docetaxel, the benefit is to patients with high volume, and abiraterone and prednisone. The current indication is high risk, which is shown at the bottom. So high volume is 4 or more bone metastasis with at least one outside of the spine and pelvis, so outside of the axial skeleton, or visceral metastasis. High-risk disease is pretty similar, and there's a lot of overlap, and it's 2 of the following: Gleason 8 or higher, 3 or more bony mets, and presence of visceral metastasis. Okay, so these are the phase 3 studies that I showed you in that timeline, and all of them have been reported. They all have either rPFS or OS as the primary endpoint, with all of them except one includes OS as a co-primary endpoint. Okay, so the first drug that was shown to enhance median overall survival when added to ADT was docetaxel, and it was tested in these 3 studies: Rettig, Charted, and Stampede. And the patients basically got ADT or ADT plus docetaxel for 6 to 9 cycles, mostly 6 cycles. Are the overall survival data. So the Rettig study on the left was the smallest. It didn't see a improvement in median overall survival based on hazard ratio. But really, when we focus on Charted and Stampede, we do see an overall survival benefit where the median overall survival benefit is about 10 to 14 months. By contrast, the median overall survival benefit of docetaxel in the metastatic RPC setting is 2.5 months. So really a much greater bang for the buck with docetaxel in the MCSPC setting. So taking a deeper dive at the Charted data, what you can see is the patient's overall survival broken down by disease volume. So high volume, there's clearly a survival benefit. The hazard ratio is 0.63, so 0.63, whereas the low volume, there's no overall survival benefit. Interestingly, in the original New England Journal paper, low volume did show an overall survival benefit, but longer follow-up, that went away. Okay, so now turn to the 4 studies that tested an androgen receptor signaling inhibitor added to ADT versus ADT only. And you have Latitude with abiraterone and prednisone, Arches with enzalutamide and ADT, Enzamet, same thing, and enzalutamide ADT, and Titan, which was apalutamide. Enzamet is the only study where there was not a placebo-controlled, but the control was a first-generation androgen receptor antagonist, which essentially is very similar to a placebo. Okay, so you can see the key inclusion criteria, but let's just take a dive into the results. This is the Stampede study. Actually, wasn't listed here, but Stampede is the largest clinical trial that's been executed in MCSPC. It's ongoing. There are constant adaptations to that study as the standard of care changes. So Stampede tested abiraterone with prednisolone, and there was an overall survival benefit in patients with metastatic disease. And again, you see a hazard ratio of 0.61. The hazard ratio for high volume disease with docetaxel was very similar, 0.63. And when you overlay the docetaxel and abiraterone curves in Stampede, you can see that they're indistinguishable. So they have a very similar benefit in metastatic castration-sensitive prostate cancer. Importantly, high-risk non-metastatic prostate cancer patients were also included in Stampede. So this is the Latitude study. This was the study that was the basis for the approval of abiraterone in the United States. These were high-risk patients. Again, that's two of the following three: Gleason 8 or higher, 3 or more bone mets, and visceral disease. The patients were stratified according to visceral disease and ECOG performance status, and the primary co-primary endpoints are rPFS and overall survival. And you can see the key secondary endpoints as well on the right. And by the way, you don't have to take notes. All of these slides, this slide deck can be downloaded. You can get all these slides from Plexus. Okay, so here are the overall survival data for Latitude. You can see a hazard ratio, again, 0.62. So you're seeing this very consistent overall survival benefit in terms of the hazard ratio, right in the 0.6 to 0.7 range. Okay, so let's turn to the hormonal signaling inhibitors that are androgen receptor antagonists, namely apalutamide and enzalutamide. They have three mechanisms of action. One, they're competitive antagonists, so they compete with androgens, testosterone, for example, for binding to the ligand binding domain of the androgen receptor. They also inhibit the androgen receptor from translocating to the nucleus. And if the androgen receptor is forced into the nucleus, the drugs will also impair the ability of the androgen receptor to bind to DNA, which of course is required for its function as a transcription factor. So here's Titan study, which is the apalutamide study, co-primary endpoints of OS and rPFS. These are, you can see the inclusion, some of the key inclusion criteria, stratification factors. And here's overall survival, hazard ratio 0.67. Again, right in that 0.6 to 0.7 range. So very similar impact on OS with apalutamide, as was observed with abiraterone and docetaxel. And here's the final analysis. This analysis was, I believe, after about 29 months. This is a final analysis, median follow-up of 44 months. And you can see that the on the left holds up. The hazard ratio is 0.65. The initial analysis, it was 0.67. And then there's a analysis on the right, which is a sensitivity analysis to account for crossover to apalutamide in the placebo arm. And as expected, the hazard ratio improves to 0.52 when one censors those patients in the placebo arm who got crossed over to apalutamide at progression, or at time of unblinding crossover, excuse me. So again, you can see these very consistent effects on overall survival with hazard ratios in the 0.6 to 0.7 range. Here's Enzamet, the first of two phase 3 studies that looked at enzalutamide in the MCSPC setting. This was a randomization to enzalutamide plus ADT versus a first generation AR inhibitor plus ADT. And you can see the some key inclusion eligibility criteria on the left, primary endpoint, overall survival. patients were stratified by planned docetaxel use. So, and a large percentage, I think almost half of the patients did end up getting docetaxel. So here's the overall survival, and the hazard ratio is 0.7, very similar to those the outcome with apalutamide and abiraterone and docetaxel. And here's ARCHES, the other phase 3 study of enzalutamide in the MCSP setting. This is the only style where the primary endpoint was rPFS only. And the hazard ratio for rPFS in favor of enzalutamide was 0.39. So 61% reduction in the risk of radiographic progression or death with the addition of enzalutamide. Here's the overall survival data for ARCHES. This was a secondary endpoint, hazard ratio 0.66. So I think you're seeing the theme here that all of these drugs for MCSPC have a very similar impact on median overall survival based on hazard ratios. Now, when this study was originally, when the Enzamet study was originally published in the New England Journal, the patients who got docetaxel did not benefit from the addition of enzalutamide. In contrast to what we'll see with the 3-drug studies. There was a follow-up study that with longer follow-up that was published on the Enzamet study, and ultimately there was a survival benefit amongst the patients who received docetaxel in that study. Okay, so going back to the ARCHES, this is just the primary endpoint based upon whether or not the patient had recurrent or de novo metastatic disease, and there's a benefit for all of those, for both of those groups. This is just a depiction of the overall survival benefit of the AR targeting agents based on disease volume. And what you can see on the far right in the boxes are the hazard ratios with all of the agents showing improved overall survival in both low or high burden metastatic CSPC. So in terms of the decision making, it makes these AR signaling inhibitors a little bit easier to select because they're kind of dummy proof. You can choose them for low or high volume, although technically abiraterone is only approved for high risk, and not all patients, say, with low volume disease, or there are many patients with low volume disease who may have high risk disease. So you can't just look at volume status. Okay, so we went through all of these studies, and this slide and the next one are really focusing on high volume, high risk versus low volume, low risk. You can see that there's a benefit of these agents for these patients with high volume or high risk. And in studies that ask the question whether or not radiation to the primary improves outcome, there is no benefit. And that's shown in the bottom 2 rows. There were 2 clinical trials that looked at this, Stampede and HORAD. Now, in this slide, we have the low volume or low risk. And what you see is that the chemotherapy largely does not improve overall survival in this population. It's actually not the case with Stampede, where you see that in the 3rd row, the hazard ratio is 0.76. So why could this be? It's probably because in the Stampede study, over 95% of the patients had de novo metastatic disease, which has a worse prognosis. In contrast, in Charted, most of the patients had recurrent metastatic disease. And then if you look at the AR pathways, they all improve overall survival. low volume, low risk, and importantly, radiation therapy to the primary also improves overall survival. I will say that I'll give you one caveat about the radiation. These are patients with low burden disease, and I suspect that a significant proportion of those patients don't have metastatic disease. So when you do a PSMA scan on patients with low volume, our data and data from UCSF have observed that half of these patients who have low volume disease on conventional imaging have non-metastatic disease on PSMA imaging. So the radiation benefit in principle might be just due to the benefit of radiation for localized disease. That's just a hypothesis. I don't know if that's true. So these are just the NCCN guidelines from April for MCSPC. I won't go through this with you. You know where you can find it. And we've gone through all this data anyhow, except for the triple drug regimens, which we'll now turn to. So there were 3 drug studies that have been reported. This is the first one, PEACE, phase 3 trial with a 2x2 factorial design in men with de novo MCSPC. Okay, so these this is the clinical trial design where the patients were randomized 1:1:1:1 to standard of care, which was ADT plus docetaxel, standard of care plus abiraterone, standard of care plus radiotherapy, and standard of care plus abiraterone and radiotherapy. Now, the radiotherapy did not impact the benefit associated with other treatments. So there was so all of the the analysis could be done irrespective of radiotherapy. So all of the patients who got docetaxel only could be combined, and all of the patients who got abiraterone could be combined. Primary endpoints were rPFS. Importantly, these patients had de novo MCSPC. They all had de novo MCSPC. So here's rPFS for the entire population, irrespective of disease volume, and there is an improvement with a hazard ratio of 0.50. Here's rPFS by disease volume. Both high volume and low volume benefit in terms of rPFS when abiraterone is added to ADT and chemotherapy, with or without radiation. The hazard ratio for high volume is 0.47, low volume 0.58. Now here's overall survival for the entire group, hazard ratio 0.75. So a benefit of adding abiraterone to ADT and docetaxel. But when we break it down by volume status, only the high volume patients so far have a survival benefit. The hazard ratio of 0.72, which is statistically significant. The low volume patients have not demonstrated an overall survival benefit as of yet. It is possible with further follow-up that we may observe a benefit. So here's the other phase 3 study that asked the question as to whether or not a third agent added to ADT and chemotherapy improves overall survival, the primary endpoint. So these were patients who had excellent performance status. They were stratified by M1 stage and whether or not the alk-phos was elevated or not. And there are multiple secondary endpoints which were analyzed in this study in a hierarchical fashion. So here's overall survival. The primary endpoint, hazard ratio 0.68. Here, 3 drugs is better than 2. Here are some of the key secondary endpoints. Time to castration-resistant prostate cancer, also markedly in favor of the addition of a dose of darolutamide. Time to symptomatic skeletal event, time to pain progression, time to subsequent anti-neoplastic therapy. All of these in favor of the addition of darolutamide or Nubeqa to ADT and docetaxel. Okay, so this was an analysis that was presented at GU ASCO, and it's a retrospective analysis of outcome based on disease volume. What you can see here is that the hazard ratio for high volume patients is 0.69, and it holds up. The upper limit of the 95 interval is clearly less than 1. Low volume patients, the hazard ratio is actually very similar, but there are not a lot of events. So the upper limit of the 95% confidence interval crosses 1. So in this context, when one looks at the hazard ratios, one could make a theoretical argument. Let's assume that this is the low volume ultimately becomes statistically significant, that the patients who have low volume disease gain more benefit. Since these patients live longer, a similar hazard ratio is going to have a greater absolute effect on median overall survival than in low volume than that would be observed in the high volume. So just to keep that in mind, it's also understood that in these 3 drug studies that the comparator arm was docetaxel and not a second hormonal agent. Okay, so here's a summary of the improved overall survival benefit in MCSPC. Again, all of this, but there's for 2 drug regimens, I think that the key take home is that the AR signaling inhibitors benefit essentially all patients, irrespective of disease volume, whereas chemotherapy largely benefits patients with high volume disease. And the 3 drug regimens that seem to improve overall survival over 2 drug regimens that contain docetaxel as the second drug. Okay, so there's the summary of the benefit of intensifying therapy. 2 drugs is better than 1, and 3 drugs seems to be better than 2, especially I think for high volume disease. And meta-analyses that have been published, I think it's pretty clear that patients with high volume disease benefit from 3 drug regimens. And I think for me, that's where I focus my efforts to get patients on a triple drug regimen. Okay, so the first case we have is a 56-year-old Black male with metastatic CSPC. In January of 2023, presents with metastatic prostate cancer with pain in the right lateral aspect of the chest, and he desires the most aggressive treatment option. PSA is 76.9, prostate needle biopsies, Gleason 5+4, bone scan, multiple bone mets throughout the axial and appendicular spine, CAT scan, no visceral or soft tissue mets. Patient has a BRCA2 mutation and has hypertension requiring 3 drugs. Which of the following would you recommend to administer to in addition to ADT? Docetaxel, olaparib, enzalutamide plus docetaxel, darolutamide plus docetaxel, abiraterone, and prednisone plus docetaxel. Okay. Darolutamide and docetaxel. Why is that? Well, the patient wants most effective therapy. Olaparib currently doesn't have an approval for MCSPC. So despite the patient having a BRCA2 mutation, the patient would not be suited for olaparib unless in the context of a clinical trial. Enzalutamide and docetaxel is not approved, and abiraterone and docetaxel, while it's an option, this abiraterone causes a lot of hypertension due to the mineralocorticoid excess syndrome. And given that the patient was on 3 drugs for his hypertension, is probably not the best option for him. So I think the best option is darolutamide and docetaxel added to ADT. Okay, so now let's turn to PSA recurrence or non-metastatic CSPC. So the nomenclature, we call it a PSA recurrence, a biochemical recurrence, or non-metastatic CSPC. These are the definitions of PSA recurrence. After surgery, it's a PSA of greater than or equal to 0.2. And after radiation, it's the nadir value plus 2. So if patients are getting hormone therapy and the PSA goes down to 0, the definition of recurrence is 2, 0 plus 2. This is the case irrespective of the use of androgen deprivation therapy, and exclude the notion of PSA bounce, which is a transient bump in PSA that occurs after radiation, months or sometimes years after radiation, often most often with brachytherapy. Okay, so what is the natural history of a biochemical recurrence? So Johns Hopkins has a longitudinal study of 450 post-RP patients who had a biochemical recurrence and did not receive treatment until the development of metastasis. So the true natural history of a biochemical recurrence. So 30% of the patients developed METs with a median follow-up of 8 years. The median metastasis-free survival was 10 years. And by the way, metastasis-free survival is the only validated surrogate for overall survival in non-metastatic prostate cancer. And the risk factors for metastasis are PSA doubling, time probability score, and time to PSA recurrence. And this is just taking a little bit of a deeper dive into the data. And the graph on the top are Gleason scores. At the time this was published, prior to 2014, they still had Gleason scores of 4 and 5, which are probably now called Gleason 6. And you can see that Gleason score and PSA doubling time on the bottom nicely stratified patients in terms of their risk for metastasis or death. This is another way of looking at the data. We'll just take an example. The far right, PSA doubling time that's greater than 15 months. The metastasis-free rate at 10 years is 72%. Conversely, if the PSA doubling time is 3 to 9 months, there's only 7% of patients who are free of METs at 10 years. And similar analysis is on the left with Gleason score. This is a table that's looking at the same data, but also including time from surgery to biochemical recurrence. And using all three of these factors, you can get a more granular estimate of the risk for prostate cancer specific death at 10 years. And you can download the slides and look at these data or go to the original paper. So let's turn to post-radiation risk factors for metastasis. It's very similar risk factors. Importantly, we don't have an analogous study with post-radiation biochemical recurrence where patients were not treated until metastasis. So the studies that were published, there was treatment that was at the time of biochemical recurrence up to the discretion of the treating physician. Bottom line is the risk factors for onset of metastasis or Gleason score, clinical stage, time to biochemical recurrence, and PSA doubling time. So very similar to that of the risk factors for metastasis after surgery, except clinical stage was not one of the factors that is predictive of metastasis for radical prostatectomy. Okay, and these are the table on the right highlights these different risk factors. So ADT, should you do it? So I said I would consider ADT in certain circumstances. If the patient has a long life expectancy, has a rapid PSA doubling time, high Gleason score, short time to biochemical recurrence. In general, however, there is no clear evidence that early intervention improves overall survival. So if you have a patient and that is compliant, is going to follow up, it's very reasonable to consider holding off on ADT. There is a study called the TOAD study that demonstrated an improved overall survival with early ADT. This was a controlled trial. However, it's an imperfect study. There was slow and incomplete accrual. The total number of deaths were low, and so it's really not a definitive study. What about intermittent ADT? So there was a phase 3 study published in 2012 in the New England Journal, which basically demonstrated that intermittent ADT is non-inferior to continuous ADT. So these were patients who had radiation, either definitive radiation or salvage radiation, and then they had to have a PSA that dropped to less than 4 after 8 months of a hormone, and it's at that time that they were randomized to continue ADT or come off ADT and reinitiate ADT when the PSA was 10 or higher. And bottom line, as I said, is intermittent ADT is non-inferior to continuous ADT, as shown in the graph on the right. In addition, there was actually a longer time to castration resistance with the intermittent ADT, even though this was not associated with an improved overall survival. I think simply that's a bonus for intermittent ADT, as well as the fact that there was improved quality of life with intermittent ADT. And 80% of the patients who had intermittent ADT recovered their serum testosterone to greater than 150 during their first cycle off of ADT. Okay, so with knowledge that intermittent ADT is a reasonable approach, this is now go over the EMBARK study, which was presented at the AUA. And these were patients who had a biochemical recurrence with PSA greater than 1 after surgery and greater than 2 after radiation. Importantly, they had a PSA doubling time of less than or equal to 9 months and no METs on conventional imaging, normal serum testosterone greater than 150. And you can see the stratification factors, and they were randomized 1:1:1 to enzalutamide plus Lupron, placebo plus Lupron, or enzalutamide monotherapy with a placebo for Lupron. And the primary endpoint was metastasis-free survival by blinded independent central review. And that the primary analysis was the combination of Lupron and enzalutamide versus Lupron alone. And these are the baseline characteristics, very similar amongst the patients in terms of age, race, PSA doubling time, etc. Here's metastasis-free survival of enzalutamide plus Lupron. So see that it's improved with a hazard ratio of 0.47. That's quite significant, 53% reduction in the risk of METs or death. And this is a forest plot comparing enzalutamide combination to the Lupron only, and you can see that there's a benefit to the combination across all of these different subgroups based on PSA doubling time, age, etc. Here's overall survival. This is also statistically significantly in favor of the combination enzalutamide ADT arm with a hazard ratio of 0.59. And here's PSA progression. Again, the combination is favored in terms of PSA progression. Now, this is the next sets of slides is enzalutamide monotherapy versus Lupron only. So here's metastasis-free survival. Interestingly, there's an improvement in MFS with enzalutamide. Enzalutamide monotherapy is better than Lupron monotherapy in terms of MFS in the biochemically recurrent setting. Overall survival, this is not statistically significant, but you can see that there's not, doesn't appear to be much difference between the two arms. Okay, time to PSA progression, as well as time to use of new anti-neoplastic therapy also favors enzalutamide over Lupron monotherapy. And this is the percentage of patients on the left with a PSA that's less than 0.2 at week 36. And you can see that the combination of enzalutamide and Lupron fares the best. Enzalutamide therapy was better than Lupron. And the median duration of treatment suspension was longest with the combination, as you'd expect. It was actually shorter with enzalutamide as compared to Lupron. My guess is that's because the enzalutamide doesn't lower testosterone. And once it clears, there's all this testosterone that's around that will stimulate the disease and cause the PSA to go up and therefore drive the reinitiation of therapy. Conversely, with Lupron, if they're on it for 8 months, it's going to take at least 8 to 12 months for those patients to recover a testosterone greater than 150. Here are the testosterone levels in the 3 arms. At the top in orange is enzalutamide monotherapy. It actually up when with enzalutamide monotherapy, which is very typical. It's what we expect with an androgen receptor antagonist by itself. And then you can see the serum testosterone levels come down when Lupron is used, and for the testosterone to recover to greater than 150. Here's some safety. Interesting, fairly similar safety profiles. This is a little bit surprising. I thought they would, actually, so for safety, the adverse events, they're similar. This is not quality of life. This is just safety. And also fairly similar safety when looking at specific events. Hot flashes is more common when Lupron is included. The fatigue, whenever enzalutamide is involved, there's more fatigue that's consistent with clinical observations. And you can see, though, many of the other adverse effects are similar amongst these different groups. So the second and last case is a 62-year-old white male with non-metastatic CSPC. In June of 2023, he presented with a rapidly rising PSA after a robot-assisted prostatectomy. In June of 2022, his first screening PSA was 22.7. He had MRI, which showed a PIRADS 5 lesion, 1.3 centimeters in the left side. An MRI fusion biopsy showed a Gleason 4+5 in 3 3/4 in the target, and systematic biopsies also demonstrated prostate cancer Gleason 4+3. His PSMA scan did not show any extra prostatic findings, and his surgery revealed a pathologic T3A Gleason 4+5 adenocarcinoma with cribriform morphology. In October of 2022, the postoperative PSA is undetectable, so a couple of months after surgery. However, the PSA starts to rapidly rise between January 23. It goes from 0.3 to 1.2 to 3.4. So a rapid PSA doubling time. And in August of 2023, conventional imaging with a CT scan and bone scan showed no evidence of disease. Likewise, a PSMA PET scan showed no evidence of recurrence. Given the patient's strong desire to aggressively treat his prostate cancer, which of the following would you recommend? A, high-dose bicalutamide, B, Lupron and abiraterone, C, Lupron and enzalutamide, D, darolutamide, or E, leuprolide. Okay. Answer is Lupron and enzalutamide, based on the EMBARK study, which showed that combination achieves the greatest metastasis-free survival, as well as overall survival, especially compared to Lupron. Darolutamide has not been tested as a monotherapy in a controlled trial, nor has Lupron and abiraterone and high-dose bicalutamide. So that's the end of my part of the talk. There's now a video that will be presented to you, and then I will stay on the line and happy to answer questions.
Hello, everyone. Thank you for joining us in this talk. I am Grace Cullen. I'm a nurse practitioner for oncology and palliative care at the Detroit VA and a member of AVAHO. I thank the organizers for this invitation to be able to give this talk on the adverse effects of treatment for metastatic castrate-sensitive prostate cancer and their multidisciplinary management. I have no relevant financial conflicts to disclose, but I need to disclose that I am a federal employee and the views and opinions expressed in this talk are not those of the U.S. government or the Veterans Health Administration. We will start with the case of Joe. He's a patient diagnosed with metastatic castrate-sensitive prostate cancer with low-volume disease. He's 73 years old. He's receiving leuprolide plus abiraterone, and you are seeing him in clinic for a follow-up. He is complaining of hot flashes. So what we do know about monotherapy using androgen deprivation is that patients can develop symptoms such as cognitive decline, cardiovascular disease, bone thinning, weight gain, loss of libido, and mood changes. When you add on additional therapy to ADT, you certainly put patients at risk for amplifying these toxicities. This would include particularly in the use of abiraterone, elevated transaminases, the possibility of skin rash, neuropathy, cytopenias, and certainly with the addition of a second agent, additional costs that can be incurred by patients. So vasomotor symptoms tend to be common. We otherwise refer to them as hot flashes. They can occur up to 80% of the time and can be associated with nausea and sweating. They can occur during sleep. So the body's internal thermostat, if you will, is usually set between 36 to 38 degrees centigrade. And with the addition of ADT or introduction of ADT into the system, it creates a stimulus of decreasing that body temperature, alerting the brain. The hypothalamus serves as the thermostat of the body. And as a reaction of the body, it tends to cause blood vessels to constrict on the skin. Physically, patients might even have signs of shivering as a reaction to this. And as a compensatory mechanism, the body tends to increase its temperature, trying to reach that threshold that has been internally set for 36 to 38 degrees. Which leads to that cycle of that symptom of hot flashes manifesting for the patient. Some triggers identified include increased temperature environmentally, stress, anxiety, and certain foods and alcohol. What we can do to try to offset this is to maintain a healthy body weight, encourage exercise and the use of appropriate clothing, and to try to avoid these triggers. Some of the management considerations that can be taken is the use of medications such as megestrol acetate and estradiol. A systematic review of data available has shown that they can be up to 75% effective in decreasing the frequency of hot flashes. They do come with bothersome side effects such as breast tenderness and enlargement, weight gain, insomnia, depression, and flu-like symptoms are some of them. Other options are selective serotonin reuptake inhibitors or serotonin norepinephrine reuptake inhibitors, which has been found to be moderately effective and have more tolerable side effects, including dry mouth, loss of appetite, and nausea. Acupuncture also has limited data of efficacy, but has only been found to be moderately effective in a limited number of published data. Gabapentin is also commonly used in a prospective double-blind placebo-controlled phase 3 clinical trial among 214 men suffering from hot flashes while taking ADT. It has been shown to decrease hot flashes to a moderate degree. So we're going to go back to our case of Joe. In this setting, how will you manage his symptoms? A, will you encourage him to have a glass of wine before going to bed? B, would you start him on megestrol acetate or gabapentin? Or will you refer him for acupuncture? So the best answer is to start him on gabapentin. And the reason is because alcohol can be a trigger for hot flashes, so you certainly would not want to encourage that. Gabapentin has been found to have more tolerable side effects. So even though megestrol is a choice, it is not necessarily the best choice if you have gabapentin available. And there's limited efficacy data on acupuncture for it to supersede your recommendation for gabapentin instead. Another common side effect we see in the use of ADT is sexual dysfunction. This is a result of decrease in testosterone levels, leading to a loss of libido, followed by erectile dysfunction, and usually occurs within the first several months of treatment. It can happen in a majority, but not all of the patients on continuous ADT. So what you want to try to do is to counsel couples even before starting them on this regimen, talk in an open, non-judgmental manner, and encourage physical affection and intimacy between the couples. This can be challenging, but affectionate gestures such as holding hands might be helpful, and this also promotes emotional and psychological bonding between the couple. Other sources of support can be found from whole health, mental health, sexual therapy, and mindfulness techniques have also been used. Another consideration is to use medication management using PDE5 inhibitors. What they do is to increase intracavernosal levels of GMP, which in turn leads to vasodilation. You have to caution patients, though, that they typically do not work sufficiently without the use of environmental and psychological cues. So again, encouraging physical intimacy and bonding is very important for this medication to be effective. This is contraindicated in patients on nitrates because it can cause potentially life-threatening hypotension. As previously mentioned, it can lead to vasodilation, leading to that potential complication. It's also worth noting that this usually kicks in 30 to 60 minutes, so patients need to plan their sexual activity around that time and can last for 4 to 5 hours. Another thing to consider as far as management is the use of vacuum therapy that's typically shown by urology to patients. Other forms of treatment that can be more local or direct is the use of intracavernosal injection of medications. It usually is administered using a very small syringe, such as an insulin syringe with a very thin needle of 26 to 30 gauge. Priapism is a condition of prolonged erection lasting over 6 hours. This is a medical emergency, so you should also educate your patients that if this happens, they need to proceed to the emergency room because it requires immediate urologic attention. And what urology typically would do is to evacuate blood that's clogged in the cavernosa. Potential permanent complications include fibrosis of the corpora nervosa and erectile dysfunction. Intraurethral injection of the medication is also a consideration. It tends to be cost prohibitive, though, so it's not really one of the more popular options out there, and also comes with penile pain and bleeding as part of its potential side effects. And if all of these fail, surgical placement of a penile prosthesis can be considered as well. So this is a procedure that can be done by urology. Other changes we tend to see with the use of ADT is gynecomastia, or enlargement of the breast. It can be treated preventatively using tamoxifen at 20 milligrams daily, or treated therapeutically with radiotherapy, mastectomy, or liposuction. This is a result of an imbalance between the effects of estrogens and androgens on breast receptors. And you might be mindful also of the fact that some patients might require some analgesia, because it can be quite painful. Genital shrinkage has also been shown to be a result of ADT. You want to provide psychological and emotional support and perhaps educate them that the option of picking clothes to camouflage this change might be an option. Another possible side effect of ADT use is bone loss and fractures. This is usually determined by performing a bone mineral density test, or BMD, and up to 5 to 10% decreased bone mineral density is seen within the first year of using ADT, and increases of risk of fractures has been seen up to 1.4 times. So you want to perform your bone mineral density test at the time of initiation of ADT and repeat it at least every 2 years for follow-up during the course of treatment. What you can educate the patients to do to try to minimize the risk of this is to observe good nutrition, perform regular exercises, avoid smoking and alcohol, and prevent falls from occurring. Prophylactic use of calcium at 1 gram daily and 400 to 800 international units of vitamin D is also recommended by the Bone Health and Osteoporosis Foundation. A tool that you can use to help you calculate for risk fractures is the FRAX tool, or Fracture Risk Assessment Tool. This is available online, would prompt you to put certain patient characteristics and information from the BMD results to help you calculate the risk fracture of your patients. Osteoclast inhibitors such as biphosphonates or denosumab is also helpful in trying to inhibit bone reception, reducing the loss of BMD. Other side effects include the loss of lean body mass, a condition otherwise known as sarcopenia, and increase of fat mass instead, which can in turn lead to metabolic changes such as increased risk for diabetes because of reduced insulin sensitivity and risk for elevated cholesterol and triglyceride levels. Fatigue can also happen, and it's not always a measure of how anemic the patients might be. They may or may not have anemia and still have fatigue. In terms of emotional or cognitive issues, it also does not necessarily correlate with the presence of depression. So patients may or may not have cognitive or mental health issues, but still suffer from fatigue. So some of the things you can advocate for is improved exercise, participation in physical or cancer rehabilitation therapy. Anemia has been also noted with the use of ADT. It can range from mild to moderate degree. Patients are rarely symptomatic from this condition, though, and from my practice, I usually see a drop of hemoglobin to no more than 2 grams. Other side effects of androgen deprivation therapy are cardiovascular effects. Surgical castration, which is not that commonly used anymore because of the availability of medications that can lead to the same effect, has been linked to higher risk of diabetes, but smaller risk of MI. Medical castration options include luteinizing hormone receptor hormone agonist as well as antagonist. Typically, we start patients on the agonist, and if we don't see a drop of testosterone levels to castrate levels of less than 50, then antagonist can be considered. Or if they're not tolerating the agonist, antagonist can also be considered. Some of the side effects we see with the use of agonist includes hypertension, increased blood glucose, stroke, and increased hypercoagulability. And for your antagonist, similar side effects have been noted, such as hypertension, risk for ischemic heart disease, as well as stroke. So when we are assessing for risks, monitoring for them, preventing them, and managing them among patients, overall, this is for the general population, not just for prostate cancer and ADT as a whole. Traditional risk assessment will include looking for baseline risk factors of 2 or more, and those are the factors we mentioned earlier, your high blood pressure, high cholesterol and triglyceride, high blood sugars, and such are among them. And when monitoring these patients, you want to try to consider the use of annual EKG to check for their risk. Blood biomarkers can also be considered to check for CVD or risk factors for CVD, particularly for patients who previously used cancer therapy that are known to be cardiotoxic. We recommend following the AHA guidelines for risk monitoring for cardiovascular disease for these patients. In terms of prevention and management, you want to follow the ABCD steps. A stands for assessment or considering the use of anticoagulation depending on your patient. B stands for blood pressure control. C stands for cigarette smoking cessation. D stands for diet, and E stands for exercise. So you want to try to improve their health by advocating for these things or monitoring some of these risk factors. Again, education of the patients are key, and aspirin or anticoagulation can be considered for certain types of patients. Now, for patients with prostate cancer receiving androgen deprivation therapy, it's important to note that those risks tend to be higher the longer they are on ADT. The type of therapy can also influence that risk. The use of gonadotropin receptor hormone agonist combined with complete androgen blockade tends to have a higher risk compared to those using early generation anti-androgens alone. And the use of GnRH agonists tend to be higher compared to the use of antagonists. So in terms of monitoring, you want to monitor and try to reverse risk factors that are reversible. Again, you want to monitor blood pressure, lipid levels, their A1C, fasting blood glucose, and try to do these things every 3 months at least if they have 2 or more risk factors. In terms of prevention and management, a multidisciplinary approach should be considered, such as the use of a cardio-oncology or general cardiology referral if you are looking at 2 or more risk factors. And social work and mental health services can be considered if they have barriers to care. We are going to move on to our second case. This is the case of Bill, who is a patient diagnosed with Gleason 8 prostate adenocarcinoma with metastasis to the bone and liver. This classifies it as a high volume disease. He's 70 years old with a past medical history significant for osteoarthritis of the hip. He uses a cane for gait stability for this reason. He lives alone and is about to start ADT with docetaxel and darolutamide. When preparing Bill for treatment, what will be the most crucial information to provide him? And we're going to go back to Bill later on. So docetaxel is a taxane that is commonly associated with neurotoxicities, which is a result of direct toxic effects of the drug to the nervous system. Sensory and motor neuropathy can be seen, but sensory tends to be more commonly seen compared to motor neuropathy. This is typically dose-dependent and cumulative, and typically presents with a stocking glove distribution on the distal body parts. Usually, it gradually improves once chemo treatment is stopped, but it can worsen first before improvement can be seen. It's worth noting, too, that for some patients, it can be persistent and chronic and can be aggravated by other underlying conditions, such as diabetic neuropathy. It can be painful, and usually patients describe the pain as a sensation of burning or pin pricking. It can result in impaired mobility and impaired ability to perform ADLs and sometimes even falls if their gaits are impacted. Some of the treatment that can be used when your patients are suffering from neuropathy related to docetaxel is the use of duloxetine. This is an antidepressant that has been found to be very effective for neuropathy. Other medications that can be considered are gabapentinoids or gabapentin, as well as topical menthol or capsaicin. Acute pain syndrome can also be seen associated with docetaxel use, which usually involves myalgias and arthralgias or muscle and bone pains and aches. NSAIDs usually are effective in controlling these symptoms. There's some limited data on the use of low-dose prednisone and opioids also, but they're largely anecdotal, so they're not commonly used in this setting. Other changes we tend to see are dermatologic, particularly involving the nail bed. Discoloration, brittleness, changes in the texture can be seen. Sometimes people might even lose their nails. This is largely due to the inactivation of the nail matrix. Inflammatory reactions can also be seen, and you have to caution patients to be mindful of signs and symptoms of infection because this can also lead to abscess formation in that area. And that can be an urgent situation that requires immediate medical attention. Otherwise, for the discoloration and changes in the texture, we offer reassurance for patients because they typically resolve again when treatment is discontinued, which allows for new nail growth on the area. And nail care is also something very important to teach your patients to observe. Alopecia or hair loss is also seen commonly, again, from the cytotoxic effects of chemo to the rapidly dividing hair matrix cells. Usually seen after the second or third cycle of docetaxel. It usually is reversible, but not always completely. So you have to counsel patients and prepare them for what is about to likely happen so they are not in shock when they start brushing their hair and seeing that a lot of them are falling off. Some patients can benefit from the use of hair wraps or wigs. Scalp cooling or hypothermia is also available as an option. It uses cooling caps to induce vasoconstriction in the area and decrease chemo delivery and effect to the scalp and the follicle cell. There's variable data though on effectiveness, so it's not very popularly used, and there are several contraindications, including the risk for scalp metastasis and certain malignancies. Unfortunately, there's currently no approved pharmacologic interventions for this symptom at this time. So moving on to your next generation anti-androgen medications, there are 4 that are out there in the market: abiraterone acetate, apalutamide, darolutamide, and enzalutamide. Zooming in on abiraterone, the risk for adrenocortical insufficiency, so patients tend to be prescribed prednisone when they are on abiraterone also. Hepatotoxicity has been noted, so make sure you're watching your transaminases, particularly for patients on this medication. For all of these medications, they have been associated with embryo-fetal toxicity, so make sure you are providing sexual counseling to your patients prior to starting them on these drugs. Seizure events have been noted on apalutamide, darolutamide, and enzalutamide. Darolutamide has been associated with ischemic heart disease, and so has apalutamide and enzalutamide. Falls and fractures have also been associated with enzalutamide and apalutamide. So some of the common adverse effects that occurred in 2 or more % of patients compared to placebo when using these drugs. Again, for abiraterone, increases in transaminases has been noted, so make sure you're watching for that. Hypokalemia has also been noted, so make sure you're checking for those levels. Apalutamide has been associated with hypertension and pruritus, among others. Darolutamide has been associated with constipation and loss of appetite, as well as hypertension, just like many of the rest of them. Enzalutamide has been associated with musculoskeletal pain, fractures, and cognitive decline. So make sure you're watching your patients for these possible symptoms associated with these drugs and counseling them before starting on the medication. Your androgen axis inhibitors, otherwise known as androgen receptor blockers, your apalutamide, darolutamide, and enzalutamide have been associated with falls and fractures. And it's unclear as to why. They're thinking some of the theory might be because it could be treatment related and related to sarcopenia and fatigue. So you want to assess patients for their risk of fall before embarking on these medications. Assess the medications they're taking that might increase their risk for falls outside of these medications and make changes as needed. Educate them that postural hypotension or drop in the blood pressure as they change positions can happen. Assess for cognitive and sensory impairment and provide aids that might be necessary and helpful. Encourage them to evaluate their own home surrounding for any hazards that can be eliminated. And provide supportive care. The use of adaptive equipment as well as a referral to physical therapy can be considered. Other side effects that have been noted that was also previously mentioned in the other slides focus on cardiovascular effects in this slide, such as hypertension, fluid retention for abiraterone, and hypokalemia. Again, hypertension has been noted on the rest of the other medications too, so make sure you're monitoring your patient's blood pressure and asking them to do the same at home, especially if they're taking blood pressure medications. Zooming in on darolutamide, we have a comparison here of a cohort of patients using the combination of daro with ADT and docetaxel versus those using ADT, docetaxel, and placebo only. And it was found that there are 4 higher grade 3 to 4 events that were seen in the combination of daro with ADT and docetaxel compared to those that used placebo with ADT and docetaxel. Particularly, they included hypertension, elevated transaminases, and weight gain. So make sure you're watching patients for this and counseling them for the same. And this is important to note that these are grade 3 to 4 adverse events. The moment you start hitting these levels, this is usually likely going to result to medication dose adjustments, perhaps holding the medication, or depending on the degree of adverse events, might even lead to cessation or switching to another agent. Further management considerations when using darolutamide, it has been noted to be associated with fatigue up to 16% of the time. So definitely encourage patients to increase their exercise on a regular basis and also encourage rest between activities. Use adaptive equipment if necessary and consider PT referral if found to be helpful. Neutropenia has been seen up to 20% of the time, and 4% can be grade 3 to 4. So you want to watch your CBC, do 1 at baseline, and monitor during the course of treatment. Watch for signs and symptoms of infection and make sure patients are up to date with their vaccines as indicated, and promote a healthy diet and lifestyle. Elevated AST and total bilirubin has also been noted, so make sure you're monitoring for these levels and try to check for over-the-counter medication or alcohol use, because that can also lead to these numbers being abnormal, and try to counsel patients on their use. So treatment of metastatic castrate-sensitive prostate cancer using androgen axis inhibitors with or without docetaxel and androgen deprivation therapy can also result in neutropenia. 10 to 14 days after treatment, you might see this take place. You would see an ANC count less than 1,500, which is by definition what neutropenia is. For some patients, it can be less than 500, which is classified as severe neutropenia. And it's worth noting that the risk of infection increases at these levels, especially if they're prolonged over 7 days. Usually, neutropenia resolves before the next course of treatment, but again, worth noting, it can be severe and prolonged and can result in fever and life-threatening infection. So very important that you're watching patients for this and educating them. Neutropenic fever, by definition, is a single temperature of 101 Fahrenheit or 100.4 Fahrenheit that is consistent over a 1-hour period of time. There's 2 tiers of neutropenic patients that we look for. We have your low-risk patients who have an ECOG-PS of 0 to 1. So these patients tend to be pretty independent and pretty mobile. They don't have hepatic or renal insufficiency. They were outpatient at the time the fever occurred, and they have no comorbid conditions requiring hospitalization. They may have had oral antibiotic treatment after a brief admission or observation. It's worth noting, though, that for most patients receiving chemo for solid tumors such as prostate cancer, there is a low risk for this. For high-risk patients, those that are diagnosed with pneumonia or other complex infection fall under this category. Those suffering from grade 3 or 4 mucositis and were inpatient at the time of the fever, suffering from significant comorbid conditions, have creatinine clearance of less than 30 and AST 5 times above that of the normal limits, admitted for IV antibiotic and required prolonged hospitalization fall under this category. So how do you manage these patients? Typically, we encourage educating patients and caregivers on symptoms to watch out for and checking their temp regularly, at least daily, if not more, advocating for a healthy diet and lifestyle and being up to date with their vaccination, to have good control of underlying comorbid conditions, and to promote good oral hygiene. The use of growth colony stimulating factor can be considered for certain patients on myelosuppressive agent who have had neutropenic fever in previous cycles also. Anemia can also be seen during the course of treatment for these patients and can result in fatigue. So you want to try to identify other correctable etiologies too and not be quick on blaming it on the medication, such as nutritional deficiencies, thyroid insufficiency, or occult blood loss from GI or GU sources. You can consider transfusing these patients if hemoglobin drops less than 10 and they are symptomatic. ESAs, or erythrocyte-stimulating agents, have been associated with increased thromboembolic events and decreased overall survival, as well as short-term mortality. So typically, their use for this population of patients is discouraged, especially if the intent of treatment is curative. So we're going to go back to Bill. Again, he's 70. History of osteoarthritis is also significant when you're looking at his records. He uses a cane for stability. He lives alone and about to start on ADT combined with docetaxel and darolutamide. So given Bill's history, what do you tell him to promote his safety during treatment? A, do you tell him to get plenty of rest and avoid getting up? B, do you tell him to use his cane to improve his balance with ambulation? C, do you tell him that burning sensation in his feet is expected and need not be reported? Or D, do you ask him to proceed to the emergency department if he develops nail discoloration? The best answer is letter B. You would advise Bill to use his cane regularly to improve his balance with ambulation. Reason being is because you actually encourage exercise. So you don't want to counsel him on avoiding getting up because that's not going to be good. Burning sensation and neuropathy can happen, but should be reported. We need to be assessing the degree for this so this can be appropriately managed. And nail discoloration is not an emergency, does not require a trip to the ED, and you can offer him reassurance. Again, these are some of the common adverse effects that we might see for patients receiving these drugs for prostate cancer. When patients are about to embark on treatment, you want to try to empower them and encourage their participation and shared decision-making. Have a detailed and open discussion with them and perhaps consider including their spouse because, like I mentioned earlier, there is a lot of sexual dysfunction and side effects that can be seen that can be impactful to the spouse as well. Recognize their potential impact to patients' quality of life. Provide literature so you can encourage discussions and questions in future visits and allow for time to ask and answer those questions. Be accessible to them and make sure they have your contact information between visits so they can reach out to you. Reassure them that you will be there to support them regardless of what treatment decisions they make. Here are additional recommendations for resources that patients can use and their caregivers as well during the course of treatment. And I thank you for your time. I'm sorry I was not able to join you in person today. And we were not able to do this in person today, but I would certainly be happy to answer any questions. My email address is grace.cullen@va.gov. And I hope you enjoy the rest of your day. Thank you very much.